So in this picture, we have demonstrated the dilated biliary radical in the upper left corner and the dilated MPD on the right side. The dilated tortuous CVD is also demonstrated beautifully in this picture. And so friend, this is T2 weighted images. And so T2, just remember the T2 just H2O. So all the fluid filled structure will be white in T2 weighted images, and all the T2, that is H2O, white, and in T1 all the fluid filled structure will be black. Welcome to our channel, viewers. So this is an interesting case of chronic pancreatitis with pseudocyst head of pancreas leading to jaundice, that is extrahepatic biliary obstruction. And we have demonstrated our management experience, and we have demonstrated our radiology. And in this patient, we manage this patient with cystogenoscopy and lateral pancreatico-biliary. That was a Izbicki procedure. So the main thing or the point which we want to highlight or to understand is that in this case, the pseudocyst head of pancreas was encasing the portal vein and was also causing obstructive jaundice. So we have divided this video in two parts to keep the video length short and to keep the interest alive. So this is the first video, and I hope you will enjoy the content. So as I said, the main highlights will be the pseudocyst replacing the head of pancreas, the portal vein coursing through the pseudocyst, and V-shaped excavation of the pancreas, that is Izbicki procedure, which we will try to demonstrate through this video tutorial. In the second part of this video, we have demonstrated the live surgery and how after opening the pseudocyst, there was a gush of fluid which came under pressure, and how we manage this patient and what are the other options surgically in case of cystic lesion of pancreas, that we will demonstrate in the second part. So stay tuned and do subscribe to our channel for future updates. We have also discussed briefly the anatomy, the CT finding and the MRCP finding. Coming to the presentation, the index case, this was a 64-year-old male. He was a known alcoholic, chronic alcoholic. So patient presented with history of pain abdomen for last 8 months. He was chronic alcoholic and smoker. There was no other comorbidity. There was no history of any diabetes. And there was history of acute onset pain 8 months back, which was radiating to back. And I showed you nausea and vomiting, which was managed in the local hospital. He also gave history of yellowish discoloration of the eyes, that is jaundice, for last 2 months, which was progressively deepening. And in the form of obstructive jaundice that was associated with high colored urine and clay colored stool with associated itching, which was more pronounced during the night times. And there was also history of undocumented weight loss with anorexia, though there was no history of steatorrhea, or that means there was no history of any fatty greasy stools. On examination, her general physical examination was essentially normal. Vital was stable. The performance status was ECOG 1. The deep ictus was positive with scratch marks present, and there was no other finding on the examination. On the abdominal examination, there was a lump palpable in the hypochondrium and epigastric region, measuring approximately 12 centimeter. It was a non-tender lump which was not moving with respiration, and there was no local rise of temperature. That means it was a lump most likely arising from the retroperitoneum, which was not moving with the respiration. And on rectal examination, there was clay color stool present, and rest was with the normal limits. So friends, I want you to pause this video at this moment and make your clinical diagnosis based upon the history and examination finding I have provided to you, and see is your diagnosis matching with our diagnosis or not, and then you can play this video after making your provisional diagnosis based upon the history and examination. So based upon these clinical findings, we had a diagnosis of obstructive jaundice with lump, and so we made a provisional diagnosis of CA periampullary. Second was CA gallbladder, as we are living in the high incidence belt of CA gallbladder that are known for these things. And the pseudocyst pancreas was third diagnosis, or the hydatid cyst was our last diagnosis. So why we have kept the diagnosis of CA pareimplicity as a first possibility is that it is an elderly male with a short history of jaundice, that is 2 months history of painless progressive jaundice. Though there was a history of pain abdomen 8 months back, we thought these two events were not related. So we kept the history of malignancy as a first possibility, that is CA pareimplicity followed by CA gallbladder. And third possibility was pseudocyst head of pancreas, as there was a history of acute pain 8 months back, and patient was a known chronic alcoholic. And last was a hydrocyst, as in our area, this is a sheep rearing area, and hydrocyst incidence and prevalence is also very high. So we investigated this patient. His routine blood examination was normal except for the raised bilirubin, which was very high to the tune of 19.36, and direct was 10.67. His OTPT, ALP were raised, and ALP was markedly raised, suggestive of obstructive jaundice pattern. His CEA and CA19 level was within normal limits. So on triphasic pancreatic protocol CT, there was bilobar HBRD as highlighted in this pic, and there was a large pseudocyst in the head of pancreas extending to the body. The GV was distended, and the CVD was also dilated. So, and there were also collateral, which can be seen in the lower pic on the right side. There were multiple collaterals surrounding the pseudocyst. There was pseudocyst with bilobar intrahepatic biliary reticle dilatation and distended gallbladder. So this is the video of triphasic CT scan abdomen. His liver was looking normal except for the bilobar HPRD, and which were dilated till the peripheral radicals, that is second order, third order radicals were dilated, and the portal vein was normal. In this freeze frame, you can appreciate there was a dilatation of the left and right hepatic radicals extending up to the secondary level biliary radicals. The portal vein was opacified normally, stomach was normally distended, and the CVD was dilated till the lower part. So in this freeze frame, you can appreciate that the pseudocyst is placing most of the head of the pancreas, and the portal vein is draping around the this pseudocyst, and there is external compression on the portal vein, which was the cause of collaterals present, and the dilated MPD can be appreciated. The pseudocyst was large, measuring approximately 8 into 8 centimeter, and as per the Courvoisier law, the GV was also distended. So we were suspicious of the malignancy also. And important finding in this patient was that there was external compression on the portal vein, and it was compressed, leading to collateral formation in the around the pseudocyst. So this picture I have already discussed, that there was bilobar IHPRD with a pseudocyst and gallbladder with collateral present around the pseudocyst, and these are the axial images or sagittal images. Sorry. So the pseudocyst and gallbladder can be appreciated, and similarly the draping around the pseudocyst or the portal vein is important. So friends, it is important to realize that pseudocyst, though it is a comparatively benign and simple condition to treat, but in this case there was a learning that the portal vein was coursing almost through the pseudocyst, and pseudocyst was draped around the portal vein. So the CT findings were there was a presence of well-defined peripherally enhancing hypodense lesion with average CT value of 15 to 20 Hounsfield per unit, measuring 7.3 into 5.1 centimeter in the head and neck region of the pancreas, with no internal calcification or mural nodule seen. It was showing wall thickness of 6.8 mm. Fat planes with adjacent organs appear to be well maintained. And lately, this mass was compressing upon the distal end of CVD, resulting in the upstream dilatation of the biliary radicals. and it was averting and compressing the portal vein inferiorly. MPD was dilated in the body and tail region, measuring up to 1 centimeter. So we also subjected this patient to MRI and MRCP to have better delineation of the ductal anatomy. And this is the video of the MRI. In this freeze frame, you can appreciate the pseudocyst. These are T2 weighted images, friends, with the distended and tortuous CVD with dilation of the intrapancreatic radicals and distended gallbladders. So, friends, I plan to make a video presentation on the biliary anatomy or the SPV radiology, so that we can better understand the uh, radiology or MRI findings in case of HPV cases. So don't forget to subscribe to our channel and hit the bell icon for all the future updates. So in this picture, another picture, this is a combination of T2 and T1 weighted images. So we can appreciate the anatomy better. T1 is for the anatomy and T2 is for the pathology. So this is the MRCP picture. MRCP is 3D reconstruction, and the pseudocyst, the dilated MPD, the tortuous CVD, and the gallbladder are very beautifully demonstrated and highlighted. So the compression was external on the CVD, and the pseudocyst was leading to the obstruction, leading to jaundice and backflow changes. The MPD was also dilated, and which was measuring up to 1 centimeter. So these are different MRCP images, and as I said earlier, also the pancreatic duct is dilated up to the secondary level of the pancreatic ductules, and the IHBRD is prominent till the secondary or tertiary level, and the pseudocyst was compressing upon the this MPD and the CBD. So this is the report of MRI MRCP in gallbladder distended, measuring 7 into 4.8 centimeter with the possible signal void and GB sludge. There was a T2 hyperdense well-defined cystic lesion within wall thickness of 7.5 mm, seen the head region of pancreas. Pancreas duct dilated, measuring up to 9 mm. Pancreas was atrophic in the body, 13 mm, 14 mm in tail. Portal vein normal, SMB is compressed by the lesion, SM is normal. And left hepatic duct 8 mm, right hepatic duct 7 mm. A common hepatic duct was 13 mm and distal CBD measuring up to 14.5 mm. So we subjected this patient to upper GI, that is gastrovidoscopy, and basically aim was to look for any external compression visible on the stomach so that he can be considered for endoscopic management, and there was none. And we also wanted to rule out barracks as there was collaterals present around the pseudocyst. So we wanted to rule out portal hypertension in barracks because the pseudocyst was compressing on the portal vein. And the gastrovidoscopy report was essentially normal. There was no bulge, no varexy. So now after the imaging, we had our final diagnosis of obstructive jaundice caused by pseudocyst head of pancreas. The malignancy was ruled, and he was a known case of chronic pancreatitis. Etiology was alcohol with exocrine insufficiency, and there was no endocrine insufficiency. So we planned this patient for Roux-en-Y cystogeneostomy with the lateral pancreaticogeneostomy, cholecystectomy, and choledochodynostomy. Why choledochodynostomy? This is a matter of debate, and we can discuss this point in some other video. But in our experience, patient after the CP phrase procedure or other draining procedure do present with the stones in the CVD, and they are very difficult to manage. So we usually consider choledochodynostomy as a part of the CVD drainage, especially in the setting of jaundice. So thanks for watching, viewers. I hope you have learned few new things about the management of CP with pseudocyst, and that will add some new insight to your knowledge. So happy learning, friends. Do like the content, subscribe to our channel, and share the information with your friends. Sharing is caring. Happy learning. Thank you very much.